meet and to have here with us Dr. Amyar. Dr. Amyar is an instructor of medicine at the Harvard Medical School and a faculty scientist in the cardiovascular division at the Beth Israel Deaconess Medical Center. That was correct. His research focuses on developing and applying artificial intelligence based on cardiovascular magnetic resonance imaging technology to advance understanding of cardiovascular diseases and improve the prediction of patient outcome. Previously, he completed his PhD at the University of Rouen in France and was a deep learning engineer at GE Healthcare, where he worked on PET and CT imaging for cancer diagnosis and prediction. Dr. Amyar research has been recognized with several awards, including the American Heart Association, Melvin Jarkin Early Career Clinical Investigator Award, the American Heart Association Career Development Award, and the Society for Cardiovascular Magnetic Resonance Early Career Award. So Dr. Amine is here with us today because he's applying to the position in our department, and this is part of the process of recruitment that he has to, he's supposed to present his work here to us. So join me and welcome.
Good morning, everyone, and thank you for the kind introduction. These are my disclosures. I think the most important one is this talk is biased towards imaging, more specifically cardiac MRI, plus artificial intelligence. So if I wanted to give this talk 10 years ago, perhaps I would have started by introducing artificial intelligence, why is it important, and why we need to use artificial intelligence. But fortunately for me, we know that artificial intelligence today is everywhere, and also in medicine. We today are trying to use AI in diagnosis to improve prognosis, and also to improve efficient use of resources. And why cardiac MRI? Why AI in cardiac MRI? Cardiac MRI is very rich modality. It allows us to capture and have any information of the heart. Usually we can have different views of the heart to look at the function, to look at the stress perfusion, and to assess if the patient has a scar. But as you can see, in a typical acquisition of MRI images, it is a lengthy exam. It can take up to 1 hour, which means there are a lot of challenges. And when we talk about challenges, we are also talking about opportunities. So, since it takes a lot of time, can we have a faster acquisition of the images? Once we have the images, we need to analyze them. So, can we have improve, like extract novel biomarkers from the images? Can we improve the prognosis of the patients using these images in patient management? And is there a way also to use efficiently these resources? There are many issues and also many opportunities in cardiac MRI using artificial intelligence, but the focus of my talk today will be based upon these three. So, for faster acquisition with artificial intelligence, I will start with myocardial T1 mapping as an example to show some work that we did in our lab. So why T1 mapping? Because we know that T1 mapping, myocardial T1 mapping, enables quantitative assessment of diffuse myocardial fibrosis. To reconstruct the T1 map, we usually acquire multiple T1 weighted images at different inversion times. And the most, the most popular sequence is the modified local inversion recovery MOLI, which is also commercially available across all vendors. And if we have a look at this sequence, usually what we do, we apply a first inversion recovery experiment to collect 5 T1 weighted images in 5 heartbeats. And then we wait for 3 heartbeats for signal recovery. And then we apply a second inversion recovery experiment to collect another 3 T1 weighted images. So in total, we have 81 weighted images that we acquire in 11 heartbeats. Of course, the heart is moving, so we have to correct for the motion. And then usually what we do is that we are going to apply a 2 or 3 parameter fitting model to obtain this T1 map. So this is lengthy. This is just for one slice, and it takes 11 seconds. So instead of doing that, we propose to apply occupational intelligence to reduce the acquisition time. So instead of 91 weighted or 81 weighted images, we'll acquire only 4. And we'll replace this fitting algorithm with a neural network to generate the T1 map. So how it works, usually when we have an artificial intelligence project, we start with the data set. This is one of the most important aspects. So we collected a large data set of 746 patients with both native and post-contrast T1, and we divided them into training, validation, and testing, with 80% in training, 10% in validation to optimize the model for parameter, and then 10% of the patients to evaluate the performance of the model. So how did we create this data set? Again, instead of having 8 or 91 weighted images, we will have only 41 weighted images that we will feed to a neural network to generate this T1 map. And then we'll compare it to the ground truth. What is the ground truth? The ground truth is the classical way of the model fitting when we acquire the 81 weighted images. Not only for native T1, but we did also for post-contrast, where we acquire also 91 weighted images and use the curve fitting. And on the other hand, we'll use machine learning to generate T1 map and compare it to the ground truth. How do we train this model? There are many strategies. We can have, for example, different models, one for the native T1, one for the post-contrast T1. We can combine them. Instead of using just for input for T1 weighted images, we can also use maybe 5 T1 weighted images because we are acquiring them in a single emergent time. So what we did is we went with a single model where we combined both the T1 and native T1 post-contrast to generate the T1 map. And in machine learning, deep learning projects, we usually have multiple hyperparameters that we need to optimize. We have the number of layers in the neural network. We have the activation function that we need to choose, how many images that we need to show the neural network, which we call the batch size, what is the learning rate, what is the algorithm that we need to use to optimize the neural network. So we did different experiments, and we ended up with a 6-layer fully connected neural network to generate this T1 map from the 41 weighted images. And to optimize this model, for people who love machine learning, you usually look at this curve, and you can see that we have a good decrease in the error for the training and the validation of the model. And to get the best model among these, we look at the values of the myocardium and the blood, because this is especially the myocardium is the most important one in this T1 map, to select our best model. Once we get the best model, then we need to evaluate it. And so we need to evaluate it in test set, which means that it was hold, it wasn't used during training. So here on the left you have the model, you have the ground truth acquired with 8 T1 weighted images, and on the right you have the images acquired with our method. We're using only 41 weighted images using 4 heartbeats. And if you look at the one analysis, you can see a very small difference between the 2 techniques. So this is for the myocardium, but we appreciate also very small differences between the values using our technique and the ground truth model. We can also look at the post-contrast images, and we see very beautiful maps that we acquire with our technique compared to the one with 91 weighted images using MOLI. And again, we see very small differences between the 2 techniques in the blood outline for the myocardium, but also for the blood. So we can use a single model trained using this combination of native and post-contrast values to obtain T1 map using only 4 T1 weighted images in 4 heartbeats. But this was a very simple neural network, so just simple fully connected neural network. And usually in the literature we see these complicated architectures. You have UNet, ResNet, have other convolutional based architectures. So we tried these different architectures to see if we can improve on what we already have. And we can see actually using this simple fully connected or just this state-of-the-art UNet, we obtained the best results while the other techniques didn't improve much. So finally we ended up with this fully connected and UNet technique. The models we build, we try to use them also in the clinic, so we have also part of inline integration. So what we did is we also integrated this model to the scanner. So we built this sequence where we have 41 weighted images on Siemens platform, and we have a server where we will send these images to the server and then send it back to the Amyar machine to obtain this T1 map. So here one of our tech applying this model on the patient, and we'll shortly see the T1 map operating. But this model was developed using only data coming from just single center, so which is our center at BMC with a single vendor and field strength with Siemens 3 Tesla. So it also asked the question, how about generalizability? Does it work also on other systems and other field strengths? Because today, if you want to translate your technique, you want also to show that it works on other systems. So we developed this scanner-independent MyoMapNet to accelerate cardiac T1 mapping across vendors and field strengths. So how we do it, we have these 41 weighted images, we add to them the corresponding averaging time, and then we encoded the vendor in a separate channel, like one for example, for Siemens and two for Philips. And then we have also information about the field strand and we encode also in the channel. We concatenated all this information and fed them to a neural network. This is unit type architecture where you have encoder and the decoder. The encoder will try to compress the information and have a good representation of the data and transform it into what we call a latent space. And then from this latent space, we'll try to map it back to an output. And in this case, the output is our T1 map, which is independent of the scanner. So to do that, again, data set is very important. We have our own data set from the BMC that we used in the previous study, but we also collected data from Coulter with Siemens 1.5 Tesla and data from Boston Medical Center with Philips 1.5 Tesla. And we divided them again into training, validation, and testing. We did the same optimization using the same hyperparameter. And again, we compare this T1 mapping we generated our technique with the ground truth, which is MOLI. And here you can also appreciate the high quality of the T1 map that we get with our technique compared to MOLI with very high correlation on BIDMC Siemens 3 Tesla. And here if you can get a deeper look at it. We get also same performance using Cornell Siemens 1.5 Tesla, and with also very high correlation between the two techniques. And finally, you can appreciate also the same quality of the images using data from BMC, and also very good correlation between the two techniques. We obtain also very high quality using the post-contrast T1 among the different vendors. And again, here you can appreciate really an excellent correlation between the two techniques. So to answer the first question, are we able to have faster acquisition? And the answer is yes. We can apply this artificial intelligence. I showed you one just of the technique for the sake of time, but actually we developed and we included this AI for many sequences that we are able now to accelerate acquisition of cardiac MRI and to use some of them in the clinic. So the second question is, can we also improve the analysis of the images? Can we extract biomarkers from these images beyond what we already have? Can we improve the diagnosis of the patients with artificial intelligence? Before going into that, I want to tell you how we manage patients in the clinic. So usually we live in the era of data, right? So we don't look at a single isolated information. We usually have data about genetics, we have biomarkers, we have history of the patient. Probably the most important information now is the history of the patients we use to manage these patients. We have other tests, we have ECG, you can have watch and record your ECG. We have different treatments. This is a very evolving field based on the history of the patients regarding the treatments and the current treatments. This will also impact prognosis of the patients. And we have imaging. So imaging is one part of in this whole system, but an important part. And the way we extract information from the images, the current traditional imaging biomarkers, is what I refer to as hypothesis-driven. What does it mean? It means by extracting these markers on knowledge-based. For example, to assess for the pumping capability, we look at short axis CNIT, to look at the left ventricular function. To assess for the disynchrony, we look at the myocardial strain. And to assess also for arrhythmia, we are going to look at the scar burden. So one of the examples on one of the markers we use a lot in the clinic is the left ventricular ejection fraction. And this came from clinical trials that were done decades ago. For example, we know that patients with low left ventricular ejection fraction are at a higher risk of sudden cardiac death. So what do? We usually draw a contour, we love drawing contours, and we look at ejection fraction. And usually if it is less than 35%, then the patient will end up with a device for the rest of their life. But if we can take a deeper look at the current, or the limitation of the current measurements, this is an example of two patients. They have the same scar volume and the same scar burden. But are they clinically the same? Do they have the same risk profile for arrhythmia? If we look at the pathophysiology, actually what we know is that the more the heterogeneous the scar, the higher the risk of arrhythmia. So today we are not taking advantage of all of the information we have in the images. But if we use computational analysis, for example, what is known as radiomics, we can extract more information. We can look at the heterogeneity of the scar. We can look at the complexity of the pattern of the scar. And here, by calculating these values, we are already able to distinguish between these patients. So how does it work usually in this radiomics workflow, which I refer to as data-driven in the opposite of hypothesis-driven? What we usually do is that we do the segmentation. So we look at the region of interest, where in this case it is the myocardium. And then we will automatically extract a lot of features. We'll extract the mean value, mean, minimum, maximum. Some of them we use in the clinic actually. But we also extract advanced features, textural features that tell us about the homogeneity or the heterogeneity of the scar and other types of features. Just to give you an example, so we speak the same language during this talk, is that we have two concepts, the image filters and the feature family. So we have the original image, which can be the T1 map in this case, but we can also apply many filters to emphasize some sort of information in the images. We can apply wavelet-based features, we can apply square root, or logarithm, and other type of features. And we have also the feature family. We can have intensity-based statistics. This is the first order statistics, but we have also, as I mentioned, textural features, where we basically are looking at the relationship between the pixel and the neighborhood to tell us about the homogeneity or the heterogeneity of the texture. So once we get all of these features, we usually end up with thousands of features. And many of them carry the same information. So we need to find the most representative one. And this step we call feature selection, where we can look at the correlation between the features. We can use some algorithms to obtain the most representative one, which we refer to as radiomic signature. And then we will use it in a model for outcome prediction or other tasks. So the question we asked was, can these features, can radiomic features, measured from late gadolinium enhancement, provide incremental value in arrhythmia risk stratification beyond what we already have, beyond standard CRR and clinical parameters? And as a case of study, we choose dilated cardiomyopathy patients. Why? Because these patients account for almost 60% of all cardiomyopathies, and also these patients are at a high risk of ventricular tachycardia and fibrillation, which causes sudden cardiac death. And this is today remaining devastating even in DCM patients. How we treat them, we usually have this implementable cardioverter defibrillator, ICD, which we use as a preventive measure. However, the issue is that only a minority of patients with ICD for primary prevention receive device therapy, which result, of course, in unnecessary cost and morbidity. So we collected two data sets, one from Cleveland Clinic with 270 patients, where 15%, 40 patients experienced fatal arrhythmia, and a second data set from our center of 113 patients, where 14% experienced ventricular tachycardia or fibrillation. We used the first cohort from Cleveland to train them to develop the model, and we used the second cohort from BME to evaluate this model, and the outcome was appropriate ICD intervention. So what we did is that we have these images where we acquire with this sequence late gadolinium enhancement to tell us if there is a scar or no in the heart, and then we extract these radiomic features that I showed you earlier. So we extract 1,005 features per slice, and then we'll average them over all the slices, so we end up with over 1,000 radiomic features. So what we did to obtain our radiomic signature, we used this supervised learning technique, which is called clustering or consensus clustering. And the idea here is that we will regroup features with similar meaning and put them into the same group. So we ended up here with 3 groups. And then in each group, we will calculate what we refer to as the midweight, which is the most representative feature in this group. So we went from 1,000 to only 3 features that summarizes the data set. And this is completely unsupervised, which means it is blinded to the outcome. So we are not trying to associate these features to the outcome. It's that we are just looking at to summarize the data set. And then we will use this in a sample regression model to which we add clinical information, clinical data, and also the presence or absence of scar or the burden of the scar. We combine them into a logistic regression model to predict if there will be a future tachycardia fibrillation events. So if we look at the evaluation of the model, we look at them in terms of IUC, the area under the rock curve, we can already see a significant improvement compared to the clinical risk score and the scar presence model, going from an AUC of 61 to 71 on the Cleveland Clinic data set, but also from 61 to 70 on the BME data set. So this is on all the patients, but we want also to look at these values at the patient level. So if we plot these features, the value of these features, first on the Cleveland data set to compare between the patients with and without events, we can see using this DLCM autocorrelation, there is significant differences between the 2 cohorts. And this is a busy table, but just to focus on the hazard risk ratio, we can again see that actually I have this feature that is really driving my, or putting a lot of weight on my predictive model. And we can observe the same thing using the BIDMC dataset with good data or a nice distinction between the two groups, even without even using this feature. And we noticed the same thing again in the hazard risk ratio model, where you can see that having an increase in this value means higher risk of what we call microcardial fibrillation for these patients. So what we did is that, again, because we are interested in translating these approaches to the clinic, so what we did is that we established a cutoff using the Cleveland Clinic dataset on this value. And we applied this same cutoff on the BIDMC dataset. And we can see a nice separation between the two groups at high risk and also at lower risk. So this was really encouraging to us to see that we can really significantly improve on what we already have. But actually we asked the question, what are these radiomic features? We know that it is, we have like some mathematical formula, it talks about homogeneity and heterogeneity, but do they have relationship that allow us to translate them into clinic? In other words, this approach does not offer insights into the biological meaning of the observed relationships. And this is an issue. Why? Because this disconnect between the model and the biological meaning will limit the clinical translation. So we asked the question, are radiomic features indicative of the underlying tissue? So what we did is we tried to investigate the relationship between radiomic feature and histological correlates in this cohort of DCM patients. So we were very fortunate to collaborate with Dr. Shiron Nakamori from Japan, from the University Hospital, where we obtained a data set with both CMR but also histology. So this is a data set of 132 DCM patients from University Hospital with CMR less than 14 days prior to endomyocardial biopsy. Most of the patients were on advanced heart failure. They had a left atrial ejection fraction of 51%, and almost 60% of them had scar. On average, the septal native T11 was elevated, and also ECV was elevated in this cohort. So what we did is that first we did endomyocardial biopsy for all patients from the right ventricular septum. We obtained 4 to 6 samples for analysis, and we looked at fibrosis, inflammation, myocyte hypertrophy, vacuolization, fat replacement, and nuclear degeneration. For cardiac MRI, we used 3 sequences. We used the T1 mapping, we used the extracellular volume, which we refer to as ECV, and we used this electrical enhancement where we look at the scar. And this time we didn't look at the whole myocardium. We only look at in the mid septum because we want to look at the exact features close to the region where we performed the biopsy. So again, we extracted these 1,023 features. We did not extract shape features because we are looking at the relationship between the texture. Here we also did, because we don't have testing data sets, so we did a reproducibility assessment on 65 patients to make sure that these features are reproducible. And then we used, again, this method, consensus hierarchical clustering, to find the most representative ones. And once we have this radiomic signature, we use this logistic regression to look if there is a relationship or association between these radiomic features and histology based on odds ratio. So again, why this consensus hierarchical clustering is because it is an unsupervised feature selection technique. What does it mean? It means it is completely blinded from histology. And here, we really group the features with similar meaning, and we put them into the same groups. So we end up in 2 or 3 groups, and in this group we calculate what we call the middle weight, which is the highest average pairwise correlation within the cluster. And this is like feature that represent that group. So for T1 radiomic features, we ended up with two big groups, and in these two big groups, we had the first feature, which is the sum entropy, and these features calculate or look at the randomness of the texture in the image. And we found that this texture was associated with fibrosis, inflammation, myocyte hypertrophy, vocalization, and fat replacement. Second feature, which we call grand length non-uniformity, which look also at the heterogeneity of the texture, and it was associated with nuclear degeneration. This is an example of a patient with low entropy value, and we can observe nearly normal findings. But when there is a high value of this sum entropy, we can appreciate fibrosis and ingoing inflammation. For ECV radiomic features, the first one was again the entropy, which also was associated with fibrosis and myocyte hypertrophy and nuclear degeneration. And the second feature was joint entropy, which measured the randomness in the intensity or neighborhood intensity in the image, and which was associated with fibrosis. So we usually, when we do this type of studies, we see these entropy features shows up a lot in our studies. And this is another example of patients with low first order entropy value, and we can again observe nearly normal findings. But when we have a high entropy value, we can observe replacement fibrosis. And finally, for red gadolinium enhancement, the first feature was the RAD percentage, which measures the porousness or the roughness of the texture in the image. And it was associated with myocyte hypertrophy. Our second feature was the dependence entropy again, and it was associated with fibrosis and vocalization. So you can see that this entropy feature is associated with fibrosis in most of these sequences. And another example of the patients with low dependence entropy value, and we see normal findings, but when we have high entropy dependence entropy value, you can observe replacement fibrosis. So we were very happy about this interpretability because we know that we can use these features to improve the prognosis, but also we know when we have a meaning of these features. And then we ask the next question. We know that cardiac MRI is the gold standard for tissue characterization of the heart. For example, if you want to look at myocarditis, amyloid, fibrin, or diffuse fibrosis, we use a cardiac MRI to assess for that. So can we, by using these radiomic features, can we do even better? And the reason for that is we know that these values that we obtain from cardiac MRI, these classical values, for example, the T1, ECV, and LGE, do not necessarily indicate myocardial fibrosis. It can be non-collagenous matrix, it can be low-grade inflammation or edema, and also combination of inflammation and reactive fibrosis. And this is very important because thyroid therapies should be provided before myocardial fibrosis develops, which has the potential to reverse disease progression. So what we did using this same cohort of 132 patients, we divided them into 4 groups based on the histopathological phenotyping. So we have a first group of nearly normal finding where the collagen volume fraction is less than 5%. We have a second group of 49 patients where there is the collagen volume fraction is less than 20%, but the differences between the extracellular space and the collagen volume fraction is higher than 15%, which means there is edema or inflammation. The third group with collagenous extracellular space expansion of 42 patients, and a fourth group of 21 patients with replacement fibrosis. So if you compare the clinical values that we get in the clinic, this native T1 and ECV, and we compare them among the 4 groups, we can see that we can easily distinguish between the nearly normal and the severe fibrosis groups. But the whole issue is when you have values in between, when you have non-collagenous versus diffuse fibrosis versus collagen group. And we can observe the same thing also using this like gadolinium enhancement when we look at the scan further. So what we did using the same technique where we extract this radiometric feature from the images, but this time because we want to distinguish between two separate groups, we use another type of feature selection, which is called the principal component analysis. And this is basically when we have these 1,000 features, you want to project them into another space that summarize and represent the data, which is basically a linear combination of these features. Once we get these principal components, we can again use them in sample logistic regression model and try to distinguish between these non-collagenous versus collagenous groups. So to evaluate our model, we can see first the limitation of what we currently have. If we look at N51 value, we have an AUC, almost a random AUC of 59%. But we can appreciate the significant improvement when we add these radiomics features and we jump to an AUC of 75%. We can observe the same thing when we use this ECD sequence going from an AUC of 55 to an AUC of 79%, and also for LGE where we go from an AUC of 54% to an AUC of 74%. So to answer the second question, can we get new biomarkers from these images? Can we improve the prognosis of the patients by showing just sample examples that works we did in our lab? So we can probably say, yes, we can do that. And then we go back to the final topic, which is the efficient use of resources. Again, cardiac MRI is lacking exam, and if we look at a typical cardiac MRI scan, we have many patients coming, so we usually will assess for the morphology and the function of the heart. We will acquire what we call CME images, and then we will inject these patients with gadolinium to obtain this late gadolinium enhancement, and we can look to identify or quantify the myocardial scar. The issue is that many patients, up to 50% of the patients, they don't have a scar. So there is a necessary use of gadolinium. And why is this important? This is important because this gadolinium-based contrast agent should be avoided when not necessarily due to many factors. One of them is the associated costs and patient inconvenience, the pollution of the environment. Actually, there was a study showing that gadolinium was in tap water in tap water-based beverages from fast foods in 6 major cities in Germany. And actually, I saw recent studies that they found the same thing in San Francisco. I don't know if it is the case also in Boston. So, and finally, there is a lack of data on long-term risk of the gadolinium retained on the body. However, it is very challenging to detect scar without using this gadolinium. So we, again, when we talk about challenges, we talk about opportunities, and we try to see if we can improve on what we already have. Can we develop this artificial intelligence technique so that we can identify patients with scar using a non-gadolinium CNE sequence, the one that I showed you, where we look only at the morphology and the function, by extracting features, textural features, and motion from the heart. So what we propose here as workflow is that we will acquire this CNE sequence, and then we will use a deep learning model as a screening tool. This deep learning model, if it tells us there is no risk of scar for this patient, then we will save this patient from unnecessary gadolinium injection. However, if there is a high probability of the scar, then we will go ahead and inject them with gadolinium and obtain these late gadolinium enhancement images. How do we do it? So I hope there are some deep learning fans in the room to going through this architecture. The input of the model is this CNE sequence, and this CNE sequence actually is 4-dimensional information. What does it mean? We acquire different slices of the heart, and the heart is moving. So we have X, Y, Z, and also T dimensions. So we can acquire 10 slices of the heart, and we can acquire 20 faces to have the dynamic conformation of the heart. And to use this into current deep learning model, it is very challenging because this is a large body information. So we developed a new architecture and a new layer that we call it conv plus 3 plus 1D. What does it mean? We'll apply first a 3D convolution. This is a special convolution that will extract features from the scene images. We'll apply a mechanism that we call it attention. Probably a lot of people are familiar with attention. This is like the basic concept that we use in many novel models, including ChatGPT, where we try to, when we extract these tons of features, we want to pay attention that we will focus only on the most important ones. And then what we do, we will reshape these features that we extracted, and then we will apply a temporal convolution, so in the T direction, to extract also information about the motion. We will again apply this attention so we can focus on the most useful, the most representative features. Once we do that, we do this what we call batch normalization, because the model is not seeing one single patient at a time, but seeing many patients at a time. So we want to have information related to the outcome. And then usually we'll reduce it and apply this residual attention blocks also, so which is success of this novel layer, but also layer normalization. And then finally, we'll repeat this extraction of features 4 times. The reason we do that is that we want to capture not only the texture, but we want also to capture the motion of the heart. Why is it important? Because we know that if there is a scar, there is a high probability that it will affect the motion of the heart. So there will be wall motion abnormalities. And we want to capture these wall motion abnormalities at different scales and at different levels. So we apply these residual attention blocks. And finally, when we have all of these features, we will use a fully connected layer to assess for the probability of the presence or the absence of scar. To develop this model, we collected a large data set of 3,000 patients from Cornell, acquired with 2 vendors, 1.3 Tesla. We divided them again into this training, validation to optimize the model, and testing. And in the testing data set, we had 500 patients where almost 200 had scar. I showed you different components of the model. So, of course, in deep learning studies, we want to do an ablation study to show the incremental value of what we are proposing. So we can look only at the special features, and we have limited sensitivity in detecting patients with scar. We can look only at the temporal features, and we have slight improvement of 77% when looking at the sensitivity of detecting patients with scar. But when we start applying this special temporal, when we combine them, we see a significant jump to an 83%, and up to 90% when we apply this attention. So we retain only the most representative features, or most important features. So we selected this model as our best model, and then we tried to do external testing. Again, in these deep learning studies, we are always afraid of overfitting our own data sets. So we do an external testing, and we collected data from 5 other centers of the data set of 1,792 patients coming from our own center, but also from Boston Medical Center, from the university, from Brigham Women's Hospital, and also from Tufts Medical Center, where 1,000 had almost 1,000 patients had scar. And we again see this improvement compared to looking only at the texture of the images, jumping from an accuracy of 64 to 78, and also sensitivity from 63 to 80. We have 2 types to simplify 2 categories of patients: patients with an ischemic scar and patients with non-ischemic scar. And when we look at the results based on these two groups. If we look at the ischemic patients, we can see very good sensitivity and also very good true positive compared to the non-ischemic. The reason for that is for a non-ischemic patient, they may have like very small scar on the mid septum, which does not affect the motion of the heart. So it will be very hard to detect it even when using this complicated acupuncture. So it is very important also to know the mode of failure of your model. And we observe the same thing using the external testing data set. So just to summarize for these three questions, can we improve on what we already have using artificial intelligence today? Can we get acquire images faster? The answer is yes, we can do that, not only in our group, but there are many groups that are working on improving image acquisition. We can also extract new biomarkers, we can improve the diagnosis and prognosis of our patients, but we can also use that for an efficient use of resources. So my key points here, and just these few examples, not only artificial intelligence is reshaping the way we analyze images, or how we acquire them and analyze them, but artificial intelligence today actually is reshaping the way we practice medicine. If you look at the clinical reports, if you look at other data sets from genomics, photomics, and we are making huge progress. But when we talk about artificial intelligence, we are usually talking about data. So this is data-driven approach, where instead of trying to base your finding on hypothesis, you have your data set and you try to uncover new insights and have new insights from your data set. But once you develop your model, you need to ask the question about the clinical utility, right? It is good to do research, but we want also to improve patient care. So how can this model impact on individual patient management level? How can we deploy them and use them in the clinic? For example, in image acquisition, we can integrate them directly into the scanner. If we want to do segmentation, we can also have our own software and improve the clinical workflow. But this is multidisciplinary approach. It is not just engineers working alone. You have to work with cardiologists, you have to work with physicists, you have to work also with biomedical engineers. So this is multidisciplinary approach. It needs also, again, a variable data set to create them, and also one thing that I always emphasize is generalizability of your model. Once you develop your model, you have also other people to be able to use it. So for the future direction, the way you see it is that instead of trying to look at these images in isolated way, you can actually, we have the tools today, we have the means to combine all of this information. You can look at the scene in the LGE, T1 maps, you can also add metadata from scanner, we can also add clinical records. And the way I see it in the next years, hopefully 5 years, is that we will have these automatic tools that does this quality control of the images, do the segmentation of the region of interest, and extract information from these images, and then make some sort of intelligent interpretation. And again, going to one of the previous slides, is that imaging is just one component in this system. And the hope is that by using artificial intelligence, we will improve the patient management compared to what we have already today. Of course, I will like to acknowledge and thank everyone from our laboratory and everyone that I had the chance to collaborate with, and I'm happy to take any questions.
Okay, open.
Thank you for your presentation. So actually, you are using the MRI imaging to see the heart. Conventionally, we use the ultrasound imaging to see the heart. So actually, did you do any assessment? So how your cardiac fMRI imaging outperform the conventional ultrasound imaging? Because you can train this model with the conventional B-mode ultrasound imaging, but you are using cardiac MRI imaging. So how it will help us compared to the conventional imaging?
Right, good question. So these are two different modalities, right?
Yeah.
Cardiac MRI is the gold standard to assess for the presence or absence of scar. So you cannot do it using ultrasound.
So from ultrasound imaging, so we cannot see this scar.
Right. So there is no free lunch. Three modalities that are complementary. Some information better you can get from one modality than the other. The way I see it, which is interesting, is that with this multimodal approach, where you can have the echo and you can have also the cardiac MRI, and try to find like a complementary way and put them into one single mode.
So I'm asking because the ultrasound imaging is so easy.
Right.
It's faster and you can use the real-time imaging. Whereas this MRI imaging technique is a lengthy process and sometimes discomfort as well. And that's why I'm thinking, so why you are using this instead of this conventional imaging method? And the last one thing, so you are using the T1 weighted imaging. So is there any specific reason to use T1 weighted imaging instead of T2 weighted imaging? Because T1 weighted imaging, as I know, is for getting the anatomical structure of the organ, whereas for T2 weighted imaging is for some pathological condition.
Right.
So then why you are using the T1 weighted?
Right. So use T1 weighted to get T1 map and use T2 weighted to get T2 map. So this T1 map is quantitative value. So we are trying to quantify the actual T1 value. We are underestimating the actual value. But it's not when you have like your images, right? The T1 weighted images. If you look at the signal intensity, it doesn't tell you anything. But if you do this mapping and you get your T1 value, there is something clinically meaningful. We know that high value, meaning, for example, fibrosis, or you have to assess for amyloidosis, we look at these values. So yes, we use T1 weighted images because we not to look at them, but because we want to generate this T1 map to get the T1 value.
So, very nice work, really cool. Couple questions. For the studies where you're tying the features to ground truth histology, I'm wondering, rather than doing kind of gross clustering, if there's an opportunity moving forward to do more of a regression analysis where you can, maybe have more continuous measurements. That's maybe answer that one first.
Yeah, that's a great question. Actually, we thought about it. And the issue was that is the number of the patients on the data set. Because it was a small data set, 152, and it was very hard to get both cardiac MRI and the myocardial biopsy. And that's why we chose this categorization, because we wanted to use an unsupervised approach, which was blinded from the histology.
And the second question was, I noticed in the spatiotemporal versus the spatial analysis you were doing at the end, the sensitivity was better in the spatiotemporal analyses, but the specificity actually took a little bit of a hit.
Right.
And just wondering kind of why that is. And what that was.
A great catch. So in this one, because the sensitivity is more important than the specificity. So that's why we want to look at different metrics. Missing a patient with a scar will have significant harm compared to injecting patients with gadolinium, even if they don't have a scar. So the most important metric here was the sensitivity.
But why was the specificity lower? Do you have a reason of why specificity dropped?
Right. I think the special model was overfitting towards specificity because there are more patients without the scar in the data set.
I want to follow with that question. It's not my area, cardio, but I do MRI in the brain. And just, you have different sequences that will give you information on tissue composition in a different way. You have inter-recovery sequence that allow you to cancel specific tissue and specific signal, T2 and T1. So in what we do in brain studies is we use T1 as an anatomical feature image, and then we use T2 and for the recovery. For example, we use FLAIR to look at Q why in cardiac MRI those techniques are not always work?
I think this is a very good question. Maybe a physicist will better answer than me. But again, I think because it comes to what we want to see. For example, for gadolinium, we want to in gadolinium enhancement, we want to look for the absence or presence of a scar. So it is more to T1 weighted because we want to know.
Right. In that case, the T1 is the one that you, you're looking for all the composition, collagens, and things like that. There's other images that allow you to capture that.
Right.
And design a specific sequence that you cancel what you don't want to see.
Right.
And that will show up. So proton density image for these things. It has been well developed for brain. Maybe the challenge has been that because of motion.
Correct.
Cardiac MRI have been focused on resources in canceling, motion correction and things like that. Focus more on volume than in the property of tissue. So maybe that.
Correct. Maybe cardiac camera people will hate me, but cardiac camera is a little bit behind compared to brain. And also, again, we have the challenges with the motion. For example, if you look at the cine images, there is a little bit of both T1 and T2, because the most important thing is that we want to look at the function. So,
Any other question?
So you mentioned that imaging isn't the only place where you see AI.
sorry, I'm not.
You mentioned that imaging isn't the only place where you think AI could assist patients. You also mentioned history. And I'm wondering, is there an ethical risk when it comes to giving AI access to sensitive medical records of patients?
Right. I was referring that we are going to build this AI. So we are going to do it ourselves. In which way you are worried about ethical?
I'm worried that if you give it to an AI, it might leak, it might not respect the privacy or respect HIPAA as well as human doctors might. So is there a way you can keep those files confidential without worrying that it might go to someone who isn't working on that patient at that moment?
Of course, we do anonymization, and so we have to protect the patient, of course. And again, I think there is different concepts. There is the concept where you have the history of the patient, and we put it into ChatGPT, and then you ask questions. And there is the second one where you build the AI tool yourself. So you are using it locally, so you don't have to worry about it.
Any other question? Okay.
Sorry, one last question. So at the end you mentioned the generalizability of your models. I saw that the inputs were coming from 1.5T as well as 3T test coils. So wondering if any tests were done to see if there was differentiability, or did it perform better on one set of machines versus others? Or in the future, as we get stronger and stronger with high resolution MRI images, are these models will still be valid given the batch normalization that you did, et cetera?
Right. We didn't observe major differences between two field strand and two numbers when we applied our technique. I think this will depend more on the number of the data sets you have.
Is that a requirement that when you have further modifications in the parameters, as the specs of the machines, you still need to train them with more data sets and then get the results?
Sorry.
Every time when there is a change in the parameter, like the specs of the machine, we still have to train the model all the time?
No, I think today we have other tools. We have something called a domain adaptation, where you don't have to retrain every time from scratch. You can use some sort of transfer learning or this domain adaptation technique, so the model will adapt to these changes. So we have a new technique. Yeah.
Okay, so we are running out of time right now, so I think we have